Okay, traumatic aortic rupture is due to trauma or drag acceleration injury. Most common is the drag acceleration injury. Okay, most commonly involved which part, that is the aortic isthmus, because this part is fixed or other aorta is not fixed. Okay, isthmus proximal descending aorta just distal to region of left subclavian artery. Okay, this part is fixed part. Okay, X-ray will show widened mediastinum. And my favorite topic is the aortic dissection. Most of the time, this CT scan will be given. This is very high G. Here you can see a flap is given. Okay, this is aorta. This is the, you can see this that is given. Also, it is given in below here. Okay, so you will have intimal tear that will create the false lumen. And which one of them is the most common risk factor for aortic dissection? It is hypertension. Okay. Other are bicuspid valve, inherited connective tissue disorder like Marfan syndrome. Also, can be common in Ehlers-Danlos syndrome. Okay, so here is the presentation. You will have tearing, sudden onset chest pain, radiating to back. Okay, and you can have marked unequal blood pressure in R. Okay, that I was actually talking about. The blood pressure difference between the arms. Okay, tearing chest pain is very important. Okay, chest X-ray will show widen, mediastinal widening. Okay, and you can develop multiple complications. There are two type of aneurysm: type A, type B. Type A involve ascending aorta. Here you can see, so you can clear it. Okay, in type 1, it is involved bold. In type 2, okay. So here a question was given in UWord, from where actually ascending from where aorta, aortic dissection is start. This is called sinotubular junction. So this point from where aortic dissection is starting, this point is called sinotubular junction. This is called sinotubular junction. This question has been asked. And for okay, for this type B, it is starting from just, okay, from the left subclavian artery. So this artery is left subclavian artery. So these points are heavy now. Okay, this okay, aortic dissection can result in acute aortic regurgitation. Okay, you will develop early diastolic murmur. Okay, okay, and then you can also develop cardiac tamponade. Bactride will be given. Treatment is the surgery. Then stand for type B, it is distal, involving the descending aorta, below the left subclavian artery. Treatment is the beta blocker. Always give short-acting beta blocker. Like, remember, give IV beta blocker, like IV osmolol, IV labetalol, IV propranolol, and then you can give vasodilator, like IV nitroprusside, IV nicardipine. Important is the nitroprusside. So first give beta blocker, then give vasodilator. Okay, remember always. Actually, if you can see, if aortic dissection progress toward aortic root, it can cause aortic regurgitation, it can cause tamponade, it can also cause MI ischemia, because it can, aortic dissection can block the coronary ostia, coronary artery ostia. So you can also develop MI. Okay. Okay. Also, you can have stroke due to carotid artery involvement, Horner syndrome due to sympathetic chain involvement. Also, you can have vocal cord paralysis. Okay. You can also have renal ischemia like that. Okay. So remember this. So history can be given of hypertension, Marfan syndrome, and cocaine. Cocaine is very important. If young patient come with aortic dissection, okay, it is cocaine that is causing that. If elder patient, hypertension is common in older patient, adult, okay, after 55. If 40-year, 30-year patient have aortic dissection, it is cocaine, okay, because you will develop sympathetic stimulation, okay, so then you can have aortic dissection. Then is subclavian steal.